Good day, everyone, and another topic from Let's Talk Medicine about septic arthritis presented by myself, Ra'a Amir. So this is the outline we have for today, so let's get started. So let's start first with the definition. So the definition of septic arthritis is basically infection of the joint. This infection can be caused by viral, bacterial, mycobacterial, or fungal causes. However, it's basically, when we say septic arthritis, we usually refer to the bacterial causes as it is the most common cause of septic arthritis. It can be called in other terms like pyogenic arthritis, suppurative arthritis, purulent, or pyarthrosis. Moving on to the epidemiology of septic arthritis. So it's basically more common in childhood, and it was found that 50% of the cases occurring in individuals less than 20 years old. So it's more common in childhood more than adulthood. It's more common in people who are less than 3 years old, and especially in that group. And it has a gender predominance in male with the gender ratio of 2 to 1. It was seen that it's affecting more of the lower limb joints. So hip and knee joints are the most commonly involved joints. Now, getting to the risk factors of septic arthritis. We can classify it according to the age group. So we can classify risk factors to the neonates who are less than 3 months old, older children, and the adults. So in neonatal period, you can think of umbilical vessel catheterization, central line, osteomyelitis, femoral blood vessel sampling. All of that can predispose to septic arthritis through the hematogenous route, which we will talk about it later. In older children, you might suspect immunodeficiency in those children, sometimes joint surgeries, and we will talk about very specific organism in joint surgeries and prosthetic joints. Hemoglobinopathies like sickle cell anemia and thalassemia, they might have more predisposition for example, salmonella organisms. Underlying arthritis can also mimic septic arthritis. Diabetes as a kind of immunodeficiency or immunocompromised patient, juvenile idiopathic arthritis. In adults, you might have degenerative joint disease as a risk factor, rheumatoid arthritis, and as we said, prosthetic joints as a very high yield to know. And finally, we have the IV drug users that as they will inoculate the organisms directly to the bloodstream. Don't forget that most of the older children, when they have bacterial arthritis, they usually have it without any chronic medical condition. So it's not necessary for the patient to have a chronic medical condition to have septic arthritis. Now, starting with the routes of the transmission. So different routes of transmission, like we have the hematogenous, which is the most important one as it is the most common way of transmission of the organism through the bloodstream, hematogenous stream. The other type is the direct inoculation transmission. This is usually with introduction of a needle like IV drug users or babies who are crawling on sharp objects. They usually have polymicrobial organisms or the atypical organisms. So in that case, it's going to be the direct inoculation transmission. We have finally the contiguous extension. This is the rarest way of transmission of the organism, and you usually see it with osteomyelitis. So osteomyelitis can have a complication as septic arthritis as an extension of that infection. So now getting into the pathophysiology, so we have two important factors that play a major role in the pathophysiology of septic arthritis. Number one, we have the synovial fluid. Number two, we have the synovial membrane. And the most important is the synovial membrane. As you can see, the synovial membrane histology in here, this is the normal histology. As you can see, there is no basement membrane. Another important feature in the synovial membrane that it has a lot of blood vessels. It's highly vascular. That's why the organisms gain very fast entry into the synovial space or the joint space. So number one, it doesn't have a basement membrane, so that's lacking of the barrier. Second of all, it is highly vascular. That's why it will disseminate fast into the joint space. And from that, the organism will infect the synovial membrane, and from the synovial membrane, it will go to the synovial fluid, causing the acute inflammation. What do we have in the acute inflammation? So in the acute inflammation, we have the neutrophils playing a major role in that, and we have the cytokines and chemokines for that also, that will induce the edema, the redness or erythema, and the other symptoms that we are going to see. And because of the edema, the joint pressure will increase, so the pressure will increase in here, leading to other complications. For example, you might have subluxation, you might have other complications that we will come upon in the upcoming slides. Now coming to my favorite part, which is the microbiology. So we will talk about the bacterial causes of the septic arthritis, as bacterial causes is the most common cause of bacterial arthritis. It can be classified into two classifications, as gram staining or as according to the age group. So as you know, we have the gram-positive organisms and the gram-negative organisms. We will start with the gram-positive organism, as it has the Staph aureus being the most common cause of septic arthritis in all age groups. So it's really important that you know, in any question, the most common organism in any age group, it's going to be Staph aureus. Another thing you should know, that it's associated with thrombosis and pulmonary disease. So you might have this as a complication or preceding events. Another thing we have is the Staph epidermis or coagulase negative staph, which is the most common cause of septic arthritis in prosthetic joints, and this is a really important information. In the second place after the Staph aureus, we have the streptococci. In the streptococci, we have three different types, as the group A streptococci in patients who are less than 5 years old, so less than 5 years old, and pneumococci in patients who are more than 2 years old. And we finally have the group B streptococci, which is really important in neonates who are less than 3 months. Now coming to the gram-negative organisms. So the gram-negative organisms, it's in the third place after the staph and strep. Of the gram-negative organism, the most common cause is the Shigella shingai. So they usually come to you and say in the lab, they say that the gram staining shows gram-negative coccobacilli, so that's usually Shigella shingai. Other causes in the gram-negative organisms can be Neisseria gonorrhea, which is seen in neonates who are less than 3 months of old, or in patients who are sexually active, especially in adolescents and adults. Neisseria meningitis has a very important characteristic rash that you have to identify it, a maculopapular rash, usually seen with meningococcemia. And this is really important that you have to immediately treat the patient so it does not progress into sepsis and death. Then we have the Haemophilus influenza as a cause, because in developing countries, low immunization rates, they might have Haemophilus influenza as cause of septic arthritis. And finally, we have the Salmonella. Salmonella is really special because it comes to a special population like sickle cell disease patients who have altisplenectomy and asplenia conditions. So that's why they are more prone to Salmonella. Now for the other classification, as we said, according to the age group, so it can be classified in patients who are less than 3 months of old or neonates, 3 months to 3 years, and patients who are more than 3 years. This is a piece of information that we mentioned before about the most common organism in prosthetic joints or artificial joints. It is Staph epidermis, or they might say coagulase negative staph. This is a table summarizing the most common organisms in each age group. So in neonates, you usually see the Staph aureus in the top of the list, and even in the other age groups. So remember, the most common cause of septic arthritis in all age groups, as we said, is going to be the Staph aureus, and the most common of the Staph aureus is going to be the MRSA. Other causes in neonates can be group B streptococci or Streptococcus agalacti, gram-negative bacilli or coccobacilli. Neisseria gonorrhea is an important organism in this age group. From 3 months to 3 years, we have other organisms like group A streptococci, Streptococcus pneumoniae, and Haemophilus influenza in people who have low immunization rates. In more than 3 years in adults, we have the group A strep pneumoniae and Neisseria gonorrhea as other causes apart from the Staph aureus. Now, coming to the clinical presentation of septic arthritis, the most important thing that they have acute onset of fever. Okay, so 2 or 5 days before the actual presentation of septic arthritis, they usually have fever and chills, and that might indicate the presence of bacteremia. Another thing, the joint itself, it might have some pain, swelling, and limited range of motion. When you have these, you should suspect septic arthritis. Another thing, there is a common presentation in children that they come to the ER limping and they have difficulty in walking. This is really important to know. So, as you know, in neonates, they cannot express pain, so they usually present with non-specific symptoms, septicemia symptoms like irritability, poor feeding, or discomfort, and usually they have multiple joints affected, and they usually also predisposed for hip and septic arthritis more than the others. In older children and adults, they usually have the fever, constitutional symptoms like malaise, poor appetite, irritability, and usually they have tachycardia. It can mimic other pathologies like, for example, other types of arthritis. That's why you should ask about the family histories and past medical history in the when you take information from the patient. And we will discuss that in the upcoming slides. After that, the diagnosis and the evaluation is made for any patient coming with joint pain and limited range of motion. So first you start with the history and physical examination. So in the history, there are some important points you have to know. For example, the pain of septic arthritis joint is not, it does not go and come. It's usually constant all the time. You should also ask about the presence of or history of joint trauma, because this can indicate direct inoculation transmission, which can mean polymicrobial septic arthritis or atypical septic arthritis like Pasteurella or brucellosis. And we will ask also about brucellosis, as we said here, in the travel history, because travel history and ingestion of raw milk can indicate also TB and brucella. Okay. Some rashes are very characteristic to some organisms like Neisseria gonorrhea and the Neisseria meningitidis, and I have pictures to show you after that. Skin and soft tissue infections, because sometimes Staph aureus and strep agalacti and pyogenes can cause some skin and soft tissue infections. Recent or concurrent illness, because sometimes we have in the differential as reactive arthritis after an upper respiratory tract infection, or GI or genitourinary infection. So it's really important to ask about this. Another thing is the onset of the most recent menses, and this is really important in the Neisseria gonorrhea because it's usually present for post-pubertal females before the menses. And usually in the first 7 days of the menstrual cycle. And as we said, the travel history and ingestion of raw milk can indicate TB or brucellosis. Immunization status because of the pneumococcal vaccine and Hep B vaccine, because they can be as causes of septic arthritis, as we know. Family history of rheumatologic disease and inflammatory bowel disease, because as we know in Crohn's disease and ulcerative colitis, arthritis can be one type of manifestation of that. Also the rheumatologic disease for rheumatoid arthritis, you have to exclude that in those patients. Another thing you should know that most of the times the septic arthritis in one affected joint, for example, when we say ankle or knee, it's not migratory. It's not going to go or affect other joints. It's really it's a very rare event. Now going to the physical examination after the history. So first of all, you will start with general inspection to the patient. They usually look ill because of the bacteremia or septicemia. They usually have ill appearance, or especially in neonates. You also should check if there is any irritability, poor feeding, like he's refusing feeding or has decreased in the appetite. Another thing you should observe is the skin examination. So skin examination is very important. You have to inspect for Neisseria gonorrhea and Neisseria meningitidis, and we will come and see pictures about that. Neisseria meningitidis, as we said, it's really important to start treatment as early as possible to prevent meningococcemia and death. After that, you should also check the eye. So eye examination is important to identify other causes of arthritis, especially in children, like reactive arthritis and Kawasaki disease. They might present with conjunctivitis or uveitis. Another thing we have is the liver examination, which can show hepatomegaly, which can be a clue of brucella when there is also a history of recent unpasteurized milk ingestion. Finally, we come to the musculoskeletal examination or examination of the affected joint, and this is really important. So when you check the affected joint, you should also check the other joints and the other bones if they are movable or not. Usually the involved joint is typically, as we said, will have erythema, edema, and warmth or high temperature and tender on palpation. Sometimes when you have septic arthritis on the hip, it's not apparent, but sometimes not apparent for the erythema and the redness, but they usually have asymmetric buttock crease or swelling of the buttock and genitalia, so that's for the hip septic arthritis. Another thing you should also consider is the active and passive motions or passive range of motion, and they are usually, both of them are decreased in the case of septic arthritis. This is a picture illustrating the disseminated gonococcal infection presenting with a vesicopustular lesion, especially at the web space in adolescents and sexually active adults. So it's really important, showing here in the first web space and in here in the sole of the foot. So this is a characteristic of disseminated gonococcal infection. This is another picture showing the acute meningococcemia skin rash, which is usually beginning as petechiae, okay, or papules. It begins as papules and progress to petechiae, and from the petechiae it will go into purpura. The purpura can progress to cause necrosis of the skin, so it's really important to identify it early to treat it. This is just an illustrating picture to show you the septic arthritis in neonates. As you can see here, you can appreciate the swelling of the knee joint. The swelling of the knee joint also, you can see in this patient that he's holding the knee in a flexed position to decrease or to have the maximum comfort of the joint space by decreasing the pressure. For example, when you extend the knee, you will have more pressure on the knee, on the joint space, and that's why they have a limping and inability to walk. This is another picture to show you also the joint effusion and the joint swelling that might happen with septic arthritis, and you should compare it with the other side too. Now, after going to the history and physical examination, then you go to the investigations. So you usually do the CBC, ESR, C-reactive protein, and the blood cultures. The CBC will show you leukocytosis, especially neutrophils. So because of the acute inflammation, as we said in the pathophysiology, so the predominant is neutrophils. ESR and C-reactive proteins, and this is important to also check for the response to the therapy. C-reactive protein is more sensitive than ESR. Blood cultures to check if there is any septicemia or bacteremia. And the gold standard in here, it's basically arthrocentesis to aspirate the joint to take a sample of the synovial fluid. When you take a sample of the synovial fluid, this is considered as diagnostic and a therapeutic way, because as we come to the surgical management of septic arthritis, aspiration is one of the ways to relieve or decrease the joint pressure. When you take the synovial fluid, as we said, this is the gold standard. You will check for the cell count. It's usually having, as we said, the predominance of neutrophils. You should also check for the gram staining, the culture, and the susceptibility testing for the better choice of antibiotics. Sometimes you might do PCR for certain organisms like Shigella kingae, but you also can identify through gram stain. cultures for unusual pathogens like TB, Pasteurella, brucellosis, and other atypical organisms. Other diagnostic tests can be in the imaging. So imaging plain X-ray is basically to exclude other causes of joint swelling or infections. For example, to exclude osteomyelitis, sometimes to exclude fractures or any other causes of osteoarticular pain. However, it does not give us the definite diagnosis of septic arthritis. Ultrasound and MRI is the best way to have an evidence of joint effusion with the clinical presentation can give you the diagnosis of septic arthritis. However, we usually use ultrasound with pediatrics because it's more cost effective and more rapidly easy access, and there is no need of sedation in children. MRI can be done in cases of osteomyelitis. Even in adults, they use the ultrasound also to check for joint effusion. They rarely go to the MRI except when they have the presence of osteomyelitis. CT also to check for other causes of joint swelling and to exclude other differential diagnoses. Okay, so just to be clear that when the patient comes to you, usually take the blood, CBC, ESR, and C-reactive proteins. You do the ultrasound to check for the effusion. You call the ortho team to come and take the needle aspiration as part of the surgical management and part of the diagnostic test. And then you send the synovial fluid for culture and gram staining. So this is the basic sequence when a patient presents to you in an ER. So now this is an X-ray of a patient having pain in the joint and fever and clinical signs and symptoms of septic arthritis. When you do an X-ray, as we said, it's to exclude other pathologies or other causes of articular pain. However, there is some signs. They are not specific, but they might give you a hint of the presence of septic arthritis. For example, you have here the joint tissue effusion. You have to compare it also with the other side. So there is here, you can see effusion and of the joint capsule. Another thing also you might check in here is the fat plane is usually displaced, as you can see. So that's usually displaced, not compared to the other side. Another thing you might check also for bone erosions. As you can see, it's apparent in this side also. Also, you can see here that the epiphyseal plate is very apparent and well defined. However, in the affected side, you can see it as not continuous line. That means there is a destruction of the epiphyseal plate. This is another picture showing you an ultrasound of the hip joint. So basically you have here the normal side of the ultrasound. So you can appreciate that this is the femur. Okay, and this is the acetabulum. Okay, so the femur in here and between the acetabulum, you don't have that anechoic space. So it's usually, there is no anechoic space in the normal joint. However, in here, you can see that there is a blackish area between the acetabulum and the femur, which can indicate the effusion, and you usually say it as anechoic fluid collection. Now finally, going to the management. So the basic goal of the management is to sterilize and decompress the joint. So this is the main aim of our management, and of course to prevent the complications that might happen because of the septic arthritis. The main cornerstone for the management of septic arthritis is basically the surgical and the antibiotics. Both of them should be used together to get the best management of the patient. Now for the antibiotics, as you know, we start empirically until the culture comes. So you do not wait for the culture results. You start with an empiric therapy, and the mainstay for the empiric therapy is usually starting with a ceftriaxone to cover the gram-negative and the gram-positive, and to cover the MRSA, we usually add vancomycin. They are the best initial empiric therapy in septic arthritis. So this is a general rule. You can have a look into the table, but however, this is just a summary for all of the empirical therapy. For example, here in 0 to 3 months, you can use any staphylococcal antibiotic like amoxicillin or nafcillin or gentamicin plus cefotaxime. This is rare, can be used because they usually say that those for MSSA. However, most common type of Staph aureus is the MRSA. That's why we usually use vancomycin. Why sometimes you use cefotaxime, not ceftriaxone? Because as we know that ceftriaxone in patients who are less than 1 month old can cause biliary sludge and therefore biliary obstruction. Also, sometimes clindamycin can be used as an alternative of vancomycin if you suspect atypical organisms and MRSA. Now, after you have the culture results, you specify your treatment according to the identified organism. For example, for the Staph aureus, as we said, you usually use the vancomycin. For the MRSA, or sometimes the clindamycin. MSSA is rare to have nowadays. However, you might use amoxicillin for that. Staph epidermidis is usually the same, vancomycin sometimes, or nafcillin or amoxicillin. Group A and Group B. Group B strep is usually through penicillin, and strep pneumoniae is according to the sensitivity toward penicillin also, but we usually use ceftriaxone. Kingella kingae and Haemophilus influenza type B, usually ceftriaxone or cefotaxime, which are third-generation cephalosporins. Okay, now going to the surgical management, which is the other cornerstone of the management of septic arthritis. We have 3 ways. Either you do arthrotomy, which is best with hip arthritis, hip septic arthritis, which is basically open surgery for debridement, or arthroscopy, which is usually better with knee joints. Needle aspiration, any joint is going to be okay with the needle aspiration, multiple or single ones. However, hip joint the arthritis is not going to be, the needle aspiration is not going to be effective in that joint. So arthrotomy is best for the hip arthritis. Arthroscopy is best with the knee septic arthritis, and needle aspiration any other joint other than the hip. Another thing you should know that the treatment of the infected prosthetic joints. As we said, the prosthetic joints, what is the most common organism? So Staph epidermidis is the most common. So Staph epidermidis is the most common organism in that. The first stage to do it is to remove the joint, treat with antibiotics for 6 to 8 weeks. And we will come to the duration of the antibiotics. So the duration of the normal antibiotic is usually 3 weeks. And shifting from IV to oral is very important. However, usually for neonates, you complete the whole 3 weeks as parenteral or IV antibiotics. In prosthetic joints, it's 6 to 8 weeks with changing or removal of the prosthetic joint. So remember this, very important, that you have to remove the prosthetic joint before you stop the treatment. Other things you should know about the management, that you have to manage the other aspects of the patient, like the pain. So you have to give pain medication, antipyretic for the fever, non-steroidal anti-inflammatory drugs for controlling of the pain in home. Sometimes they use dexamethasone to decrease the inflammation. However, this is controversial if it's effective or not in septic arthritis. And the most important aspect is the physical therapy. The aim of the physical therapy is basically to move or to make the joint mobile, or mobilization, to prevent any contractures, any other complications that might happen because of the immobilization. So this is a very important aspect you should put in mind. Another thing you should put in mind, when do we say this is very there is a response to the therapy? So you do the clinical and laboratory response. So you check for any improvement in those 2 aspects. For example, you have resolution of the fever, decreased joint pain, swelling, or erythema, increased joint mobility, decrease in the white blood cells, either peripherally or in the peripheral blood, or even in the synovial blood with the in the synovial fluid with the aspirations, and also decrease in the ESR and the C-reactive protein. C-reactive protein, as we said, it is more sensitive than the ESR. That's why it's usually used for checking the response of the therapy. Now going to the complications of the septic arthritis. We have many different complications, and some of them they are very specific to specific joints. For example, joint laxity, subluxation, dislocation. This can happen in any joint, especially the knee joint. Joint restriction and limited range of motion. Limb length disparity, especially if the growth plate or the epiphyseal plate is affected. So this is very important that's why it's really important to treat children. Avascular necrosis, and that's when you have increase in the joint pressure that will compress on the vessels, and that will cause decrease in the blood flow. That's why you will have avascular necrosis, especially at the femoral head. Okay, femoral head is very important site for avascular necrosis. Another thing you might have is enlargement of the femoral head, which is called in children coxa magna. Okay, coxa magna deformity. That's why also another reason for you to treat septic arthritis promptly in children. Sometimes you might also have pathological fractures. Another thing you should know that even with treatment, approximately 40% of the patients of the hip involvement, and about 10% of the people who have knee septic arthritis, they usually end up with complication. For example, when you have a question, if who's more prone to have a complication, a patient with hip septic arthritis or a patient with a knee septic arthritis, it's usually the hip septic arthritis that have a higher rate of or higher percentage of complications. And finally, we got to the end of this lecture. Here are the references I used, and thank you for listening.